Welcome to The Breakdown, the orthopedic podcast where we dig deep into the world of bones, joints, and everything orthopedics. I'm your host, Lauren, and today we're diving into something that's become a frustrating and all too common roadblock in patient care. The topic today is prior authorization. Those two words can delay care, frustrate physicians, and confuse patients. It's a system that was designed to control costs, but now it's starting to control outcomes. It's time we start questioning the process. Let me ask you this. Have you or someone you know ever needed a medical service, maybe an MRI, maybe even surgery, only to be told you need prior authorization? And then you go through all the hoops to attempt to get authorized, but instead you get denied. Now what? Do you wait? Do you appeal? Why is this happening? And what are insurance companies getting out of this? Today, we're joined by Dr. Daniel Davis, a board-certified orthopedic surgeon specializing in shoulder and elbow surgery right here at Rothman Orthopaedics. Dr. Davis is here to talk through what prior authorization really means, how it's affecting both patients and providers, and what real actionable solutions could look like. Dr. Davis, thank you for being here. Welcome. Welcome to our show.
Thanks for having me. Yeah, I'm excited to be here. Excited to be here in person.
Wonderful. Okay, so let's start with the basics. So for those that might not be familiar, what exactly is prior authorization?
Yeah, so prior authorization is a process whereby insurance companies want to see what you're planning to do for a patient, whether it's surgical, prescribing medication, getting imaging, and you have to submit to them what you're planning to do, and then they approve or deny certain codes, which is how we kind of bill for things in medicine. And it's nothing new. It's been going on for decades, really. Since the 1960s, insurance companies have tried to have some oversight over what physicians or hospitals are billing for, with the idea that maybe there was some overbilling or just making sure that things are being done correctly and they're paying for what is actually being done. It's gotten a little more contentious, I would say, in recent years, especially medications is really the biggest thing that people have an issue with prior authorization. But from an orthopedic perspective, it's usually surgical cases and to some degree imaging, to where sometimes, we have to go through extra steps to make sure that we can get procedures approved that we think our patients need.
That's what I was going to ask. So this is something that spans across all of medicine, all specialties, all practices.
Yes.
When it comes to orthopedics, it's mostly for surgery, studies, and medication, you mentioned too?
Yeah, for medication, it's probably not as much relevant for us. That's more hematology, oncology, so like cancer medications.
Yes.
And that's probably the biggest issue of prior authorization.
Really?
I can't speak to that in as much detail, but I know that that's a bigger area just because there's so many new developmental drugs that are very expensive.
Right.
And so that's why prior authorization comes in for those.
Got it.
For orthopedics, by and large, surgical cases or surgical procedures are those things that we're looking to help to treat our patients. Probably a lesser extent imaging, although people do have issues with prior authorization for imaging, especially MRIs, because they can be more expensive. Usually by the time a patient is coming to see us, they've had kind of all the appropriate treatments or boxes checked, so to speak, that we can, for the most part, pretty easily order imaging if we need it.
And by us, you mean surgeons.
Orthopedic surgeons.
Right.
Yes,
because within Rothman, we have the whole non-operative team. So for them, it may come into play more. It might be more of an issue. And it is, from talking to my colleagues that do that, it's definitely more of an issue. Obviously, they're not scheduling patients for surgery, so they don't have to worry about that part of it, but they certainly do have some issues and holdups with ordering imaging if it gets to that, yes. Does that come into play if you're a surgeon versus a non-surgeon with prior authorization? Does that matter, like that an insurance company would authorize something coming from a surgeon more so than they would a non-operative?
It seems to. I don't know the specifics of why that would be, but there are many times I'll see patients who, or talk to primary care doctors even, who will say, well, we just want you to see the orthopedic surgeon because they're not going to get your MRI denied, whereas we will. And I don't know if that's because they're not kind of going through what the insurance company wants you to go through, or sometimes maybe
interesting,
the steps that you need to have before getting the imaging. Or that we have sometimes that experience to say, like, based on our physical exam findings and looking at their x-rays, that, there is a high likelihood that they have a rotator cuff repair and they're a younger patient, that we don't want to delay this, so we should get the MRI.
Yeah.
And by doing that, a lot of times we can get them approved pretty easily, but we still have to go through the process a lot of times.
Exactly. So you have to exhaust all of the non-operative, I guess, like if it's for a surgery, right? Like exhaust all the non-operative treatments first.
Yeah, that's in theory. Yeah. And that's what the challenge is. And that's what people do get frustrating with is, you ask that question of something very specific, but it's hard to nail it down on that, because there are so many things that we're doing, so many procedures that we're doing to get approval of, that you don't always know exactly what the insurance company wants you to have to get that prior authorization or to get that procedure approved.
Wait a minute, hold the phone. So what exactly is a prior authorization? It's when your doctor has to explain to your insurance company why a test, procedure, or medication is necessary. And the insurance company has to agree that it's necessary in order for them to pay for it. Not all insurance plans require prior authorization. However, many do. All right, let's get back to our conversation. So sort of the reason behind it is twofold. One, cost, so that the insurance companies could contain costs, so that there's not all of these studies just being done, or whatever that aren't needed, but also for patient care too, that a patient is, and this is where I kind of want to go down, and I might be jumping the gun here, but how would an insurance company know what's best for the patient? Who's on the other side of the authorization?
It's a good question, and it's really dependent on, I think, the insurance company and what kind of system they use for prior authorization, which is another frustrating part of it, is that different insurance companies have different systems.
Okay.
And I think some do work well. The people to answer the question directly, it's many times physicians that are on the other side of that.
Okay.
So there are physicians that are either directly employed by insurance companies or employed by these clearinghouses, which insurance companies will then contract with to go through that process. Some definitely work better than others. I think many are getting better, some through required legislation, which I know we'll get to in a little bit, but others just by wanting to do a better job and wanting to help the system. Yeah. So there are some where, and I don't find this as much anymore, but this definitely used to be the way 5-10 years ago, where you're trying to schedule a patient for an orthopedic procedure and you're talking to a family medicine doctor on a peer-to-peer phone call, or you're having your case reviewed by, a retired cardiologist. Well, they know a lot about their field, but they might not know as much about orthopedics.
Right.
And so generally if it ever gets to the point of a peer-to-peer, and a peer-to-peer is an actual phone call between me, the treating physician, and the medical reviewer physician who has reviewed the case. So that's why it's peer-to-peer.
Got it.
And in those times when you had like a non-orthopedic surgeon that you're discussing the case with, they by and large always approved it, because they were like, listen, you know more about this than I do. But depending on their clearinghouse rules, who they work for, some companies were very strict and said, well, if you didn't go through physical therapy and do this, then no, we're still going to deny it.
Right.
Those are definitely cases that would drive a lot of frustration for orthopedic surgeons, because, they're not there seeing the patients.
Right.
As I alluded to, however, I think there are some companies that are doing a better job of that. They're having orthopedic surgeons review orthopedic surgeon cases. They're having, even down to the subspecialty of orthopedic surgeons, they're having like a shoulder specialist review shoulder cases, a spine specialist review spine cases. They're having cardiologists review cardiac cases. And they also are using those physicians to help build their guidelines, which they then go to the insurance company and said, these are our guidelines, which we think are appropriate based off the best evidence that our group of physicians have come up with. And then the insurance companies can say, okay, we're good with your protocols. And And I think that will help as more of that develops in the future in limiting the frustration that the treating physician has with it, because hopefully that will limit the times that cases are denied or going to peer-to-peer, which is really where the frustration comes from.
Cut. Let's say that again. Okay, so who's on the other side of that prior authorization? As Dr. Davis said, it's often a physician. However, it can be a nurse or a reviewer who is using standardized criteria to make the call. They're ultimately deciding if the requested service meets the guidelines of the insurance company. Okay, let's jump back in with Dr. Davis to find out how physicians can avoid a denial.
A lot of surgeons can probably avoid the frustration of that process by having really good notes on what they do, which is, it's, again, a point of frustration, but it's also like, well, you're having a third party that's paying for this and they want to make sure that they're spending their money appropriately. So you should let them know what you found in your exam, what you see on your imaging, and your interpretation of it, what the patient has already done to try and help with the problem.
So let's talk through that a little bit more. So by notes, you mean when you dictate
Correct.
At the end of
Yes.
seeing your patient,
Right.
or while you're seeing the patient, you're dictating your note on what transpired during your interaction and what you're seeing in the studies that they had done or whatever the case may be, because everything is case dependent. So do you mean like using keywords in your dictation or key finding, like just making it as description
as clear
rich
as possible, right? And the more that you do this, the more the certain things that are needed, and not that you're making anything up, but just making sure that you're correctly documenting what you saw that is going to limit that slowdown in that prior authorization process.
Is this something that you get in training as becoming a physician, or you just kind of pick it up along the way?
A little. I mean, it's certainly not a formal part of the training, but I think it's something where we can do a good job or better job probably with teaching our residents of saying like, hey, it's important. I mean, the most important thing is to document what you saw.
Exactly.
And document what's actually happening. Obviously, I would never condone like making something up to get something approved. And I don't think people are doing that, but they also might not be putting the most clear information in the note that could make it a lot easier to work through that process.
So let's take one example just so we can kind of walk through all of the following steps with it. So when you have a patient that has to get something, a surgery, let's just say a surgery like you mentioned, prior authorization, pre-authorized for, what is the process right there for the patient on the patient side? Do they have to do anything at all besides wait?
In our practice, usually not. Usually we take care of all of that on our end. And so, like I said, it goes to our billing office and they, we obviously take care of them from a patient-facing side, like with our surgery schedulers who's working with them, letting them know what they need to do as far as getting clearances and making sure they're getting appropriate blood work and all those sorts of things.
Time out. Me again. So what's the patient have to do for a prior authorization? As Dr. Davis said, not much. It's mostly on your doctor's office to submit the paperwork. But if it gets denied, you might have to step in. Call your insurance company, file an appeal, or work with your physician on next steps. All right, let's get back into it. So let's talk about a time where, and maybe not with you personally, but where a patient is denied. They were all set up and ready to have the surgery, and insurance is saying, nope, we're not approving it.
I know.
What happens?
It's a huge issue for my partners who do total joints, total knee replacement, and total hip replacement. A couple of factors that play into that are patients' body habitus. So there had been some evidence showing that patients with a BMI over a certain amount, like a body mass index over a certain number, have worse outcomes after total joint arthroplasty. And so, I mean, we as a practice would instill those kind of rules too, just so that, we can make sure our patients are getting the best outcomes.
Right, for sure.
There has been some other evidence that says, you can still do it safely in patients who are above that level as well, as long as, they're being managed appropriately and have appropriate expectations. Well, insurance companies might lag behind on getting some of that data, and they try and base it off evidence, but then they try and also just kind of stick to their guns and say they're not going to change. And so there might be people who need to lose a little weight, might do a little better after their surgery if they lost a little weight, but the insurance company is saying, well, nope, like you can't do that. And so it's this really tough conundrum for that specific example where, to really lose weight, well, a patient needs to exercise, obviously have a healthy diet, but they have debilitating hip arthritis, so they can't exercise. It's like this real
we just had Dr.
in.
Kugelman on a couple shows ago about Ozempic.
And
using Ozempic, which has come
that's been a big factor for, that was actually just going through my mind as I was saying that, because I think that has helped with that, where people are able to lose that weight and be able to then get their surgery.
Right. Oh my gosh. So then at that point, the patient is sort of left in this space where they have to, and going to another surgeon is not going to, like if they say, this doctor couldn't help me, let me go see someone else.
If it's because the insurance company isn't approving, it doesn't matter who you go to. Right. Yeah. So it's tough. And I think it's a tough thing because on the one hand, somebody might argue, well, it's a hip replacement. It's an elective procedure. It's not life or death. But there's time spent working, time spent with your family, doing other things that is lost when you can't do that. And actually some of my partners just published some studies showing that for some of these like hip and knee cases that are delayed or denied, with the thought being that you're saving the system money by avoiding the potential complications. That's kind of the theory of why you would be denying it. There's a lot of extra treatment or lost time or lost work that's done that actually might outweigh any of those costs.
Right. Yeah. And other medical conditions that can come into play. I mean, if they're not active anymore and, being active, that's the best medicine, right?
Yeah, right. Yeah. For sure.
When a denial comes through, does the insurance company or the physician on the other side give any suggestions, or is it just denied, move on? Do they say could do this, that, and the other
that goes
instead?
Back to which company you're dealing with.
Okay.
So I think some will tell you, kind of lead you on, and it depends like the doctor you're talking to. Some are trying to be more helpful for you.
Right.
Some just kind of stick by their rules and say like, nope, it's denied. And so usually it's either it gets straight denied, and then you have the option to appeal. And that might mean submitting more information. It might mean asking for a peer-to-peer or doing a peer-to-peer phone call, or to some percentage is probably just give up and don't. And the patient says, okay, well, I just won't do this.
So let's talk about Medicare, because traditional Medicare does not require prior authorization. And why is that?
Yeah. So Medicare obviously started in the 1960s as more or less like a public insurance option to cover patients who are 65 and older, as well as patients with disabilities. Mm-hmm. The original form of Medicare, there's Medicare A, Part B. So Part A covers hospital stay. Part B covers physician services, kind of generalized.
Okay.
Medicare Part C was created in the late 90s as part of the Balanced Budget Act. And that's actually where Medicare Advantage was started. So a lot of people now hear about Medicare Advantage. Right. So those Part A, Part B, that's your traditional Medicare. And that was, you get reimbursed for whatever you say you're going to do or whatever you are doing. There's no prior authorization. There's really very little oversight in it, which was great for care for seniors. But it ballooned the system, right? And so and obviously now, especially as, our population of patients over 65 is getting quite large, and even was starting to happen 30 years ago, that really grew that Medicare budget. So as a way to try and curb that, they created this Part C Medicare, which is where a private insurer is given a certain amount of money from Medicare per patient, and then they manage that patient's care. Mm-hmm. And so they manage it just in the same way that they manage their normal private.
So is that like a Keystone
patients.
65 plus?
Yeah, exactly right.
Got it.
And so that was started, as I said, in, I believe, 1997 or 98.
Right.
And so there were like 0 patients in Medicare Advantage in the late 90s. Mm-hmm. There are now, I think, I looked it up yesterday, 33 million patients that are in Medicare Advantage, which is about 55% of everyone in Medicare.
Right.
So
Oh,
you have a
wow.
majority of patients who are in Medicare who use Medicare Advantage. And because it's managed by these private insurers, they are then able to do things like, and that was the whole point, was basically, we'll give you this set of money, and you as a private company are theoretically going to be more efficient than the federal government doing this. But then what that meant is maybe stripping. Now there were certain rules and stipulations that it had to be equivalent to the care that a patient would have gotten under traditional Medicare, right? So you can't like deny services that they would have gotten otherwise. However, I think they can weave around those rules by saying that they still want you to meet certain criteria or try different treatments that might make it more cost effective. That would be the argument for it. So that's why there are certain federal legislation pieces, which we can get into, which can go after prior authorization, because prior authorization from a private side is not completely going to be mandated by the federal government. They can't really control what a private company is doing. But if it's Medicare, they can.
Got it. Let's talk about the Seniors Timely Access to Care Act. So that's a recent legislation that is being proposed. And tell us about it.
So that
I'm just learning this
focusing
for the first time today.
on Medicare Advantage. And trying to legislate what the insurance companies who manage these Medicare Advantage plans are able to do, and it's really focused on prior authorization to hopefully curb any delay in treatment for patients under these programs. So there's more or less like three main features of it. They want to require the amount of time that it takes from a claim being submitted to when somebody gets
to make sure
find
that
out
they're turning it around quickly.
They want to try and mandate kind of a computer system that is being used to be able to submit these claims and have them come back. A lot of the prior authorization system is actually built on like an old fax system where you literally have to it's not like you're actually putting it in a fax machine and like, hearing the dial tone, but like when we send stuff from our computers, we technically fax them. You like put in a phone number in the computer and it goes through the fax
fax line. Oh my gosh.
So, a little inefficiency there. And so they'd like to try and make a way for that to move more efficiently. And then I believe, I'm not 100% sure, but I don't know if it has also this gold card feature to it, which is a system that's been instilled in different states to limit or to help with the prior authorization problem. What that is if you look at a physician who is doing a good job, every time they submit a claim, it's getting approved. They're not getting a lot of claims kicked back at them. They're not having to do a lot of peer-to-peers. They're obviously documenting things appropriately, getting them submitted appropriately. Then, maybe that person should just not have to go through the extra burden. And so it's this gold card system. So the downside of that some will argue is that if you're in a practice that maybe doesn't have the resources to efficiently submit your claims and have it done well, that maybe you're getting more kicked back because of that. So that would be the downside. But the upside is hopefully most people are able to do that appropriately and then can move through the system more quickly.
Are the physicians on the other end anonymous? Like, do you
you
know
who they are?
You do.
Says they say their name, and so sometimes you know who they are.
I was going to say, do you ever know them? Like, I went to med school with that guy,
and
and he
reasonable
failed.
people. No,
and he wasn't a good doctor.
No, there's some good doctors that do it.
Has that ever come up? Oh my gosh.
I think, and some of the company, I'm familiar with the company Turning Point, that they do a lot of this work and they hire really good people. They actually have like multiple past presidents, the academy involved. And so they're like they work with the academy, the American Academy of Orthopedic Surgeons, which is our kind of national organization, as well as our subspecialty societies, to make sure that they're trying to do the right thing and they're trying to set up protocols that are appropriate so that, we can try and make this process work.
If there's one thing you wish every lawmaker or insurance executive could understand about this process, what would that be for you?
I would just want them to know that physicians, by and large, like, we're trying to help people.
Exactly.
Like, that's what we're here to do. We're, if you're in it just to make a ton of money, you're in the wrong business.
Right.
Because it's not a great, like, I know people who work a lot less than I do that make a lot more money,
Right.
you know? And so you got to work a lot, and but it's rewarding, and
Of
we enjoy it,
course,
and we
when
want
you
to take
see
care of
patients
people.
that are,
and so,
happy again and not
you know,
in
we're
pain.
just trying to do the best we can, trying to make the best decisions we can. It's an inexact science in what we do. And we're trying our best to help
It's
people.
funny. I was talking to a physician last night who recently retired, and I was telling him about, our show that we were going to do today. And he said, that's one of the reasons why I retired early. He said that whole movement, he said it just got too hard. He said it got too hard, and and it was taking away from him truly enjoying, coming to work every day and caring for the patient. Do you feel that it comes into play?
It is tough to answer. I mean, not so much that it would like drive me out of it, or drive people away, or drive me to recommend people do something else. Like if that's what they really want to do, we're going to need good doctors, right? So my father's a physician, and
is he?
Not that he never like drove me away or drove me into it. Quite frankly, it was just if that's what I wanted to do. Yeah. I've certainly a lot of his friends that I would run across in the hospital or anything when I was growing up that would say like, oh, this isn't the same that it was when we started. And it wasn't. And it was different. Each decade, each year is different as this landscape changes. But I still think it's a great job to be in. And I think we all really enjoy doing it.
And I'm sure things have gotten better. Of course, things, get different, maybe more difficult
some
in
things are
certain
better,
areas,
some things are
but
worse. Yeah, exactly.
Right. Exactly. There's a nice balance. I'd like to thank Dr. Davis for his insight on this topic, and to all of you, thank you for taking the time to listen. I'm so grateful. Please take a moment to share this episode with anyone that you might know who has dealt with or is in the process of requesting a prior authorization. Knowledge is power. Stay tuned for more episodes, and until then, stay healthy, stay strong, and take charge of your health. I'm Lauren, and you've been listening to The Breakdown.